This video was written in conjunction with Tifa Min. She is a VTuber, VSinger, Utaite, and recent PharmD graduate. Please check her out. How do doctors know how to treat pain? Before we start going into any medications, it's important to understand the types of pain and how to measure it. Pain is a response that involves the peripheral and central nervous system. It's meant to protect the body from further harm. For example, like touching a hot stove. You feel pain, and you know to not do it again. But sometimes the nervous system can function abnormally, leading to pain that's not linked to something that the body can avoid. There are also differences between acute and chronic pain. The 2022 CDC Clinical Practice Guideline for Prescribing Opioids for Pain defines acute pain as time-limited and sudden in onset. Common examples of situations where someone might have acute pain are nociceptive pain, cuts, burns, and bruises, which are common after injuries, surgery, and trauma, or labor and childbirth, or migraines and headaches. Acute pain can become chronic pain, which is pain that lasts at least 3 to 6 months, depending on where it's defined. Common examples of chronic pain include musculoskeletal pain, such as arthritis and fibromyalgia, neuropathic pain, such as diabetic neuropathy or carpal tunnel, or cancer pain, which can be caused by mass effect or as side effects from treatments like chemotherapy or radiation. But how is pain measured? Well, pain is subjective, which means that each person interprets their own pain differently. The most common tool for a healthcare provider to help understand a patient's pain is the visual analog pain scale. If the patient is unable to talk, like when they're intubated, other tools can also be used, like the critical pain observation tool and the behavioral pain scale, where the provider observes the patient's facial expression and body movements for signs of pain. Reliability of these tools are increased when multiple providers assess the patient and come to a general agreement on their level of pain. Overall, the goal of pain control is to provide the patient comfort and reduce distress. Uncontrolled pain has shown to lead to slower recovery, which means a longer hospital stay, higher cost of care, and impaired quality of life outside of the hospital, such as mood changes and decreased mobility. Modern clinical practice guidelines generally recommend multimodal pain management, which is a simultaneous use of 2 or more analgesic drugs with different mechanisms of action. This combination can have a synergistic effect. This means that when adding the effects of the medications taken together, the combined effect is more than the sum. Multimodal pain management is used to reduce the need for high doses of a single pain medication and prevent overuse of powerful medications like opioids, overall which have more severe adverse effects than non-opioids. A multimodal guideline that I personally subscribe to and use in clinical practice is the WHO Pain Ladder. This tool was originally developed for use in cancer pain, but it's still a useful method to understand when to use different pain therapies. There are 3 main principles. By the mouth. Oral formulations are preferred as the safest method of administration. By the clock. Scheduling pain medication to get pain relief throughout the day for predicted pain, and then adding on more only when needed for breakthrough pain. And by the ladder. Start with non-opioid pain therapies first, then add on opioids if the patient isn't getting adequate pain relief. In most hospitals and doctors' offices, non-opioids are commonly used in mild pain scenarios rated 1 to 3 out of 10, while opioid medications are typically reserved for moderate 4 to 6 to severe 7 to 10 pain. Non-opioid drugs include acetaminophen, Tylenol, and non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen, naproxen, and ketorolac, Toradol. In addition to these, non-pharmacological interventions may also be used, such as physical therapy or heat and cold packs. Non-opioid adjuvants are drugs that can be useful in different pain types, such as gabapentin or pregabalin being used for neuropathic pain. By the pain ladder, oral opioids are a much more preferred starting place than hitting everything IV. And in addition to medications like oral oxycodone or hydrocodone, there are also formulations combined with a dose of acetaminophen like Percocet, Vicodin, and Norco. But if opioids provide the strongest pain relief, why don't we use them first? Or as much of it as we can for all patients in pain. Like all medications, opioids carry risk in use. But unlike all medications, these risks are more precariously life-threatening. An opioid overdose can cause central nervous system or respiratory depression, or a patient can get so sedated from the opioid that they stop breathing. This is a medical emergency. Because different people metabolize and react to the same opioid dose differently, we can't always predict what a safe maximum dose is for each patient. Pain relief is also individual, which means different people can have different reactions to the same opioid dose. This makes starting an opioid as a first-line method for a patient just an inappropriate option overall. In the long run, hyperalgesia is also a problem. This is a paradoxical condition where nociceptive pain receptor sensitization is caused by prolonged exposure to opioids. And finally, one of the most common side effects is opioid-induced constipation, which is reported in up to 80% of patients that take opioids for any length of time. Oh, constipation, how does that work? Well, pharmacologically, opioids are mu receptor agonist drugs that work at the ascending pain pathway within the central nervous system. Opioids activate the mu receptor at both the pre- and post-synapse levels, preventing neurotransmission of the pain signal. This reduces the perception of pain by the brain, but also leads to other effects such as euphoria, sedation, and respiratory depression. Unfortunately, there are also mu receptors in the GI tract, and when opioids bind to those receptors, it can slow down the normal movement of the digestive tract, causing symptoms like nausea and constipation. There are also different classifications of opioids that we can utilize in practice. We use these classifications and structural similarities to predict if the patient will have a reaction to other opioids. There are the naturally occurring opiates, like morphine and codeine, semi-synthetic opioids like hydrocodone, hydromorphone, and oxycodone, and synthetic opioids such as fentanyl, methadone, and tramadol. For example, some patients can have an allergic reaction to morphine sulfate. If they still require higher pain relief, we would also have to avoid codeine, but we may find success administering fentanyl instead. How are opioids used? We give small and short-lasting doses of opioids for a variety of procedures and conditions at the hospital. These can be in the form of oral doses to small intravenous injections, or they can be limited to local applications like creams or patches. Continuous IVs or drips are more commonly used in the ICU, where there's a lower nurse-to-patient ratio that allows them to be more closely monitored for signs of respiratory depression. In the ICU or in hospice care settings, you may also see PCAs, or patient-controlled analgesia pumps. These use a continuous infusion rate plus a button controlled by the patient to deliver a small extra dose during those short spikes of high pain. The healthcare team limits the dose given by the time and amount for the patient's safety with the delay interval, lockout, and hour limit. We can also monitor how often and when the patient presses the button to calculate if we need to increase or decrease the amount of pain medication given. In the US, we use the opioid risk evaluation and mitigation strategy to ensure that both providers and patients understand the risks of opioid use and when to not use them. Outside of the potential for opioid abuse and misuse, we also want to prevent lethal central nervous system depression. This means that patients should not be on other medications that can cause CNS depression, like benzodiazepines like Xanax, or barbiturates like Nembutal. If a patient is taking an extended release formulation, it's important to educate them to not crush or chew it, which can release all of the drug at once instead of over time, leading to an overdose. It's also important to keep your medicines secure and prevent others from having access to your opioid prescription. Fatal overdoses can occur in children and people who have never been exposed to opioids before. In the case of overdose, you may have heard of naloxone, which comes in nasal spray or IV form, also known as Narcan. Naloxone is a rapid-acting opioid antagonist. It binds to the opioid receptor and it has a much stronger affinity to the receptor than the opioid itself. This displaces the opioid from the receptor, which does mean that the pain control effects of the opioid will rapidly wear off, but more importantly, it will also reverse the central nervous system depression during an overdose to restore breathing. In the hospital, naloxone is kept on hand when increasing the dose or converting to a different opioid, as a patient may have a different response to a different opioid. But accidental overdoses at home can easily happen if the patient takes their opioid dose more often than directed, such as forgetting when they last took it, or combining opioids with other CNS depressants such as alcohol. A patient losing consciousness due to respiratory depression isn't going to be able to give themselves naloxone, so it's important to educate family and friends on how to administer it. Just like with CPR, the public should be informed about recognizing the signs of an opioid emergency, such as unusual sleepiness or unresponsiveness, slow or no breathing, slow heartbeat, tiny pupils, cold or clammy skin, and bluish nails or lips. More importantly, regardless if the patient wakes up or not, emergency services must be called immediately after administering naloxone to further manage the consequences of CNS depression or withdrawal. Okay, that was a lot, but I hope from this video I could help you understand how doctors approach pain and demystify what opioids are. It's important for healthcare providers to listen to the patient, because only you fully understand your own pain. Opioids can be useful for moderate to severe pain relief in many different conditions, but also have a variety of dangerous and adverse effects. We also covered how you, as a member of society, can help prevent a fatal overdose in a friend, family member, or a complete stranger. Stay safe out there.